Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. My name is Peter Johnston and I am the Vice President for Workforce and Corporate Engagement. I'm very pleased to be hosting this webinar today, and we've got some leading experts and authors of the dataset for histopathological reporting of penile and distal urethral cancer guidelines. The point of this is there will be some clarifying and clarification around aspects of the guidelines that members may find difficult to implement, and some practical tips and clinical scenarios that may be of use to us when we're reporting these cases. There'll also be time to answer your questions. So I'm very pleased to introduce to you today's speakers and authors of this guideline. The first is Dr. Pedro Oliveira, and the second is Dr. John Oxley. Before we start the webinar, I'd just like to keep you up to date with how this works. The presentation will last about 15 minutes, which will leave us about 20 minutes for questions and answers. All the participants should be muted. And if you want to ask a question, please do so using the Q&A function, because the chat is not open. So if you want to ask us a question, put it in the Q&A, and we will try and pull the questions together and address them in the second 20 minutes of this webinar. So without further ado, I would just like to start this by welcoming our speakers. Over to you, Pedro. Thank you very much.
Thank you very much. Welcome everyone. And we are going here, I'm going to start presenting my screen. So we are going to discuss today on this webinar the dataset for penile and distal urethra. And the first thing is why it took us so long to upgrade the edition from 2015, the third and last one, to 2024, which is 9 years, which is too much for normally for the Royal College of Pathology guidelines. One of the reasons behind it was that we were waiting for the 5th edition of the WHO classification for the urinary and genitourinary tumors, because we knew in advance that some important changes will be implemented and we will wanted to follow the same guidelines and the same classification. And in addition, there was also the COVID period, who also delayed everything for everyone in the world. So what is the main difference between the previous edition and second edition and the classification now on the penile cancers on the WHO is that finally, after a long period, we understood that the initial last classification that was endorsed and by the College of American Pathologists, that means the lower anogenital tract terminology, was being introduced to penile cancer, changing the traditional morphological approach for the classification. So this was a huge change in concept and has tremendous implications that we need to follow. So now, from now on, we have understood that there are two main carcinogenesis associated with all the squamous lesions, either in situ, either invasive, on the penis and distal urethra. The ones which are associated with HPV and the others which are independent of HPV. This is a foremost change, and this applies to both in situ and invasive squamous lesions. And for that to be achieved, to be precise in terms of the classification, there is a thing that we all need to do, which is P16 immunohistochemistry. And the reason why we choose to do the P16 immunohistochemistry is not because it identifies the ones who are definitely with the virus, is because it's the best method that we have so far to discriminate between the two carcinogenesis model. It's not perfect, but it's the best one. So the first idea that became written on these guidelines and also in other guidelines like the EAU and the ASCO, is that P16 immunohistochemistry is a requirement. It's no longer an option, is mandatory to be done for the purpose of classifying properly the in situ and invasive lesions, independent of the morphology that we were used to consider prior on the classification. Why we choose the P16? For many reasons. One is because it is available in most of the labs, at least in England, in the immunohistochemical panel, because the extension of the introduction many years ago of the P16 in cervical lesions being transform it as a routine antibody in any department. The second is because its publications on the literature have shown, like in cervical cancer, in penile cancer also, is a good surrogate marker for and reliable marker for HPV infection, and then also because it's the simplest and easiest way for the proper classification. It's not 100% perfect, but we don't have any other that can be simpler and easiest than the P16 immunohistochemistry. People may ask us, why is this so important? The reason why these become a new paradigm on the penile cancer is because penile cancer was delayed like other cancers in terms of this bimodal model of carcinogenesis. And the experience from other cancers, mainly, for example, the head and neck cancers associated with HPV and anal cancers, we have seen that HPV-associated lesions behave differently with a better outcome, are more prone to be managed by radiation therapy, and also because the staging system, at least for oral cancer, has changed in terms of the TNM. Will be this the case for penile cancer? We don't know yet. What we know so far is that the historical data has been, mixing cases with HPV positive and HPV negative, because most, let's say a large proportion of cases which doesn't show the morphological characteristics that we were used to call associated with HPV, that means cases which didn't show the usual, what we define as usual type squamous cell carcinoma, we know by immunohistochemistry that a considerable proportion shows HPV integration and shows staining for P16. So this means that the historical data that we have been used to define treatment, management, outcome, everything for penile cancer has been mixing two different carcinogenesis models, and this has been shown by comparison with other cancers that we need to do this difference, because probably we will end up treating penile cancers, HPV associated versus HPV independent, differently in the future. Another thing is, and people sometimes talk about it, is that what we have in addition that can be important on penile cancer. I will just address some of the questions that normally people put me. The first is the grading system and stage. Grade and stage, which are provided by pathologists, are very important in the decision to go for the sentinel lymph node biopsy on the lymph nodes. Grade, we all know that is very subjective in penile cancer. It's not perfect. Can we replace it by anything else? Can we improve it in another way? So far, there is no data to do it other than it was published. So we remained with the same system as before, because we don't have data to support or change the grading system. And we think it's still important because of the management issues. The same regarding stage. Stage is by the YCC and the American Joint Committee on Cancer responsibility, we all know as pathologists that sometimes we have difficulties in terms of invasion and for example, the corpus spongiosum versus the lamina propria, in terms of how important is a booting on the albuginea, invading the albuginea, or going to corpora cavernosum in some of the lesions. And these are things that we also don't know if they are relevant or not, but also both grade and stage will also to be considered in the future based on the dichotomy between HPV-independent and HPV-associated lesions. What about other markers like P53 and Ki67, mainly for differentiated, what was called differentiated PIN, which now will be called HPV-independent PIN, from other inflammatory dermatosis like BXO in aspects, morphological aspects, where we feel differential diagnosis is very difficult. So far, there is no convincing evidence to support the use of both in this setting. So we don't have data as so far to support that, okay, if we have a pattern of P53 as like one which we can use the same for vulva, do this means that we are dealing or not with a malignant lesion? Unfortunately, we don't have this data, so we need to rely with the traditional morphological aspects that we have been considered in the prior guidelines published. A final word regarding the Sentinel lymph node biopsy protocol. As you know, Sentinel lymph node biopsy protocol is part of is instituted as a routine in most of the cancer centers where penile cancer is treated in England. And we have devised a protocol that implies another sectioning and immunohistochemical performance with at least 2 cytokeratins. We don't have data to show that this needs to be replaced by just 1 cytokeratin, for example, CK56, and we don't also have data to support if it is truly relevant, the identification of micrometastases in sentinel lymph nodes like it is on the melanoma. So we don't have data, so everything stayed as before. The only thing I would want to comment is that also there is no definitive criteria sometimes for identification of extracapsular extension. Extracapsular extension, as you all know, it's very important on the inguinal lymph node metastases of penile cancer because it put on the N3 category and mostly imply assessment either of the pelvic lymph nodes or treatment by radiation therapy of the pelvic nodes. So, or neoadjuvant radiation therapy. So the question remains that in some cases, because of the inflammatory reaction of the capsule of the lymph node, it's tricky to use it. There are no criteria, definitely, for what is best, how to address some of these difficult cases. So we left these to the common sense of the pathologist to be sure about when to describe the extracapsular extensions. What are the future directions? There are many things that we don't put on the guidelines, like, for example, some strict indications how to grow. We left these to the, like before, to the each of the labs. However, we strongly recommend that on cutting the penile specimens, the pathologist need to be sure that the way he's doing it allows them to understand the complex anatomy of the organ, because otherwise it's very difficult to stage the lesions. Also, some specific guidelines have been issued according to some uncommon procedures or less common procedures, like, for example, glands resurfacing excisions, which have been described and needs to be followed. More things that can happen in the future? Well, I think that the most important thing is that from now on, we will have cases properly classified according to the HPV association versus HPV independence. I'm sure that the future will prove that P16 positivity will have a different outcome from cases which show P16 negativity. This has been our experience at the Christie Hospital so far in the analysis of our series, and this has been also the experience of large epidemiological studies coming from Norway that was published this year. So it seems that we are seeding a future where perhaps we will see in the next 3 years or in the next decade a huge change of penile cancer management based on a pathology decision of identifying or not the HPV association. That's it. So I will stop sharing, and I don't know, John, if you want to comment anything else, and then we can address the questions. Thank you, sir, everyone.
John?
I've got nothing to ask or say.
Perfect. So let's see the questions.
Thank you very much. Yeah, I'm going to start with HPV. You mentioned that IHC was the best method. One thing that I was wondering was about the use of in situ or genomic testing for HPV. And there is a question in also about which centres in the UK actually do HPV testing in urology cases. So I guess the centres, the question really refers to genomic
testing. Yes.
Yeah. So
molecular testing. This is a very good question, and I must say that I don't know how to answer this, because I don't think that the genomic labs of the NHS, I believe we have 9 or 7 centers that centralize the genomic in the NHS. They have a specific HPV assessment for penile cancers. It's mostly done in some of the labs, eventually, or in the pathology academic departments. I don't know, John, do you want to comment on these?
So we do in situ HPV for low and high risks, because we have it here because of the cervical workload. So we can do it. So they're the ones where you're thinking it's warty, the P16 is negative, and then you think, well, is it a high risk HPV or is it a low risk HPV, and is it actually a viral wart? So in those situations, it's useful. The P16, it's not useful realistically in your tumours. It's more useful in your papillomatous thing. Is this a viral wart? And if it is a viral wart, does it have P16 expression? And should I be worried? And should I be telling the clinicians I should be worried? So we do in situ. Now, for the HPV subtyping, that can be done. We do it in some skin pathology cases because certain tumours are associated with certain HPV subtypes. And that can be done in a commercial setting. We send ours to London. But I don't think there should be any reason in the penile setting that we should be doing these. I think we should restrict ourselves to P16 on the invasive tumours. And if it looks basiloid and you think, God, this is going to be a case of HPV related and it's going to be P16, and it comes back P16 negative, I would just shrug my shoulders. I certainly wouldn't go on and do HPV subtypes, because of the cases that I have done that on, it's actually been negative. So the P16 does seem to be quite reliable, but as Pedro, as you said, we're getting lots and lots of cases that you would classify as HPV related, and the P16 comes back as negative. So it's a whole mindset.
Yes, it is. It is, and indeed, there is another problem with the RNA-ish for P16 is for HPV is very costly. It's not difficult, but it's very costly. So I believe that at this moment, for the time being, let's each of us stay with P16 immunohistochemistry, because it's available, it's always tested. We have 10 years of experience with it. there will be some cases, but that we will have to put it in the shelf in terms of to understand better in the future, but there is no, let's say, consistent need to recur to genomic testing on most of our cases on a routine basis. Addressing the second question, which is the problem of the usual type, the reason why P16 is important, because we have also in our experience lots of cases that we will just say this is a usual type with no warty, with no basaloid features, and we test for P16, and it shows the pattern that we describe as strongly basal positive and block staining, and we just classify these. I stress again, we need to clear our mind in relation to the historical approach based on morphological patterns, because it's not useful anymore at this moment, and it's going to compromise us in achieving the understanding of penile cancer for the future in terms of the dichotomy HPV-associated versus HPV-independent. We can and we should use the terminology as something after labeling HPV-independent, HPV-associated, as just because we are pathologists and we have been for a long time using terms like basaloid, warty, and subtyping the different types. But in my own perspective, seeing about 150 new cases per year, I must say that what is important at this moment is to be sure that we separate the HPV ones from the HPV independent. Going to another of the questions.
Sorry, Pedro,
yes.
To pick up on the point of the P16 and HPV testing, there's one of the comments from Marie O'Donnell which talks about the apparent inconsistencies and where we would sometimes expect to find HPV positive, it's negative, and sometimes when you'd expect it to be negative, it's positive. To what extent do you think that's real, and to what extent do you think it's just particularly the genetics testing that isn't as good as it might be? Without any offence to the lab's concern, but we know it's not as reliable sometimes as people would like us to believe.
Yes, that's a very important thing. My personal approach is one of pragmatic. I would say that about 95% of all the cases will fit with the P16 immunohistochemistry quite well. 5% of the cases will be outliers. How to approach these outliers? Okay, you can do, like Marie O'Donnell have said, we can do the genomic, but we don't know yet why they express differently. And one of the reasons is the integration of the HPV, is the subtype of the virus. So these cases are cases that need to be addressed in a large multi-center study in order to define if indeed the absence of P16 would put them differently from the other HPV-associated P16 positivity. I would recommend people to put these cases on a database and record them independently so we can put all together later in order to understand why this is happening. Because just from a morphological point of view, why do we have cases where we know that they are associated with high-grade HPV and some are basaloid, the others are warty, and the others are usual? What makes the difference when we know that the virus is the same? Probably is the integration in the genome of the cells, and do these means or do these explain the different immune landscape, the different morphological pattern? We also don't know that in penile cancers. So I think that we need to start thinking in a very ground basis first, and then emerging to more deeper studies for cases like Maria identify. It's very interesting because the same thing has been occurred and has been published on the American Journal of Surgical Pathology regarding lesions that we will, in old times, we all would define them as undifferentiated PIN, and when you do P16 is completely negative, and when you do genomic is completely negative. So we have still areas of outliers and interface, but fortunately, these are very minor areas. I think I addressed that is my explanation for everything, and that is my recommendation for the approach in terms of practical aspects.
Thank you. That's very helpful. I think, and then the way that it seems to me then is that the bulk of these cases behave the way they should in terms of morphology with HPV association, but there are always going to be some that it's not what we anticipate. And I guess under those circumstances, what we're doing is using our experience to guide the surgeons best as to how the future treatment should go. Just if I may, you're nodding, so that's I'll take that as okay. Just want to move on because when we're talking about future management, there is a question about HPV vaccination, and it was one of the things that I wondered about when we were considering this webinar, was what is the role of HPV vaccination in men, and how does it work, and does it work, and is there evidence that it might?
Well, I must say,
prevent the development of these cancers in the first instance.
Okay, I must say two things. The first thing is that there is no studies showing that in HPV-associated in situ lesions, the vaccination will gonna have a change in terms of the ability to impeach development of a cancer. There is no studies on that. So we don't have yet any information that shows that vaccination is useful in cases of in situ lesions which associated with HPV, which are the ones that theoretically have the propensity to develop as tumors. Second, there is also no evidence that by being a HPV positive tumor, by vaccinating the person, because we are talking of a group of people that are mainly on the 50 to the 60-year-old, so that are much predate the immunization programs that have been developed for HPV. There is no study so far clinically that show that by vaccinating a HPV positive tumor, for example, if it is a PT1B, would impeach the development of lymph node metastases or later metastases. We are completely on an unknown territory. So the only thing I can say is that despite what we will think, that like in head and neck cancers, we have been assisting on a progressive trend that HPV is being the dominant factor in terms of carcinogenesis. Our analysis at the Christie, using about 900 cases from the last 11 years, showed that consistently we have 50% of the cases associated with HPV, but we have 50% which are HPV independent, this just based on P16 immunohistochemistry. This means that we still have to tackle the 50% that are not associated with HPV that we expect in the future, in the next 30 years, to reduce because of the extending of the immunization programs to the males.
Thank you. That's interesting. John, have you any comments to make on this one?
No, I think it's right. They do talk about it, the MDTs, but the logics would appear that the HPV is integrated into the cell and the cancer line has already started. So giving them HPV, you've missed the opportunity, the window of treatment before it happens. So we'll have to wait for the other studies, and presumably there are trials of other HPV-related tumours in that point of view. I was going to ask a question of Pedro, because you raised Sentinel lymph node protocols, and the fact that the protocol which we've designed it uses 2 antibodies. And has Manchester kept with the 2 antibodies, or have you slipped to 1 antibody?
We still kept, for one simple reason, is the guidelines. But my own experience is that CK5/6 would be enough to let's say, to pick up all the metastases, because it seems to be the best marker in terms of cytokeratin for penile squamous lesions, in my own experience. So in the future, I would say that if we have a study that validates and one antibody versus the two antibodies that currently were on the guidelines, we can propose these as the new guidelines. So far, we don't have it. But in the meantime, we all need to be aware that digital pathology is being taking place. We have already commercial available software to identify metastatic lymph nodes in breast cancer and in other settings on a similar protocol of sentinel lymph node biopsies. So perhaps in the future, we will not rely on the immunohistochemistry, we will rely on add-ons provided by these artificial intelligence algorithms. So there is also a working to be done on this area. So far, my main concern is not the identification of minor isolated cells, because we have, in our experience, a study with 9 cases that didn't have any impact at all in the outcome. But the most important thing is that about the extension outside of the capsule. Do you want to comment this, John, how you approach the extranodal extension? Because this is something that makes a huge difference in terms of management and in terms of staging.
Yeah, I think that's an interesting question. I had that one down, actually, because particularly in the groin, determining where the lymph node capsule is can sometimes be quite difficult, especially at the hilar aspect of the node. So, yeah, that's a good question.
I mean, personally speaking, we just, difficult cases we show around and come to a consensus amongst ourselves. I mean, I think there's no, I mean, it's probably, in terms of actually what happens to the patient, it's probably more important than the HPV status, because if they receive radiotherapy or not based on the extracapsular extension, I think they do fall into sort of two camps. They're either obvious or they're a bit tricky. And I tend to probably give them the benefit of the doubt and call them extracapsular extension because of the fact that they'll receive extra therapy. So I would probably err on being sort of a bit more generous in the definition, but it's always going to be subjective, isn't it? I mean, that's why pathology keeps us busy.
and just as a lymphoma man, I would have to add in that there is a danger in relying wholly on your cytokeratin in the lymph node, because there are always these cis tentacular cells that are lurking around in lymph nodes that do stain positively with cytokeratin. So it's important to correlate what the IHC is saying with the morphology, so that we don't overstate what we're seeing. Are there any other questions around that?
There is a question that I want to comment. Do you recommend doing P16 and P53 in all penile cancers with atypia, like in vulvar lesions? Pathology recommend P53 and P16 in all preneoplastic lesions. Okay. P16, we are settled. P53 is a very interesting thing, because only recently, studies from the group of Leuven in Belgium came up with defining that P53 can be important in terms of a prognostic marker, perhaps even better than P16 or HPV versus non-HPV association. But this is just one study, and this is not definitive, solid in terms of comparison. So we need to address this issue, and then most important, we need to identify how can we use the P53 immunohistochemistry in order to get the information regarding to be wild type or mutant type. So far, the best approach has been a paper by the group of Rigauer in Austria, which seemed to be using the same approach that we use for vulvar diseases. That means the completely negative, the ones with basal overexpression, the others which show throughout all positive, and also a continuous setting on the layers of the epithelium. So Why we don't recommend? We don't recommend because we cannot at this moment have support for the literature to say, okay, if we use these, we can be sure that this is a type A, B, C, D, whatever you want to do it. We can just recommend, if you want to use it, B, again, use your good sense, because this is something that can be had. Sometimes it will be confusing, so it's up to the pathologist to judge how to interpret the findings. I must say personally that I have been doing this systematically now for all the penile cancers, not in terms of diagnosis, but just in terms of my understanding for the future, if this proves to be something that I can extract information that will be on the future significant to tailor different approaches. So I don't recommend it at this moment as a guideline for diagnosis. I rely on morphology.
Yeah, thank you. There's a question about grading. In your talk, you mentioned that grading was a tricky issue. And I see a question which is asking about, should we be grading HPV-associated pre-neoplastic lesions further than just saying it's HPV-associated, I presume, and correlating that with whether it's flat or warty. How would you respond to that question?
Well, at this moment, we first need to understand that once we do this dichotomy and once we have on our, let's say, experience, the differentiation of HPV versus non-HPV, this is the first thing that we need to address. Then, once we have this completely defined, we need to think that, is there any benefit? Is there anything that accrue by using a grading schema for these lesions? Because before, we were using it by extrapolating and translating concepts from the dysplasia in cervix to the lesions in the penis. But in the cervix, we now know that some of the lesions that we saw were not initially associated with high-risk HPV. Now that we have the P16, and we always know that P16 is associated with high-risk incorporation, I don't think there is a role or there is a need and there is no benefit to classify, to turn more complexity than the one that just simply say HPV-associated PIN, HPV-independent PIN.
Okay, thanks. Just there's another question which takes us back to the title, actually, still cancer. And we've not spoken a great deal about that. And so there's a question in which is asking about HPV status and its relationship to urethral cancer. And I wonder how those two are related, and if you've got any comments, either of you, on HPV and urethral cancers.
Well, the first thing on the urethral cancers is that the urethra is a very complex structure because it goes through different anatomical places. So when we talk about the urethra, we need to be very careful where we cannot extend the concepts and the information from the bladder to the distal urethra, which is an interface area, which probably is more akin to the glans epithelium surface than to the bladder urothelium. So what I do is that and that's the reason why we call it penile and distal urethra. You all remember the times when the urethral invasion was considered on the TNM staging. This has become completely out of the staging system because we cannot have anatomically a truly definition and separation from the distal urethra from the penile cases. So, and also biologically, they look the same. Most of them look like a squamous cell carcinoma. So for practical purposes, we, by definition, all the cases which are in the distal area of the urethra should be regarded as the same way as a squamous cell carcinoma of the, let's say, of the epithelium of the surface of the glands and foreskin. The urethral cases, for me, the urethral carcinomas are the ones who appear on the membranous urethra or in the prostatic urethra. The others, it's very uncommon to have a urethral primary cancer other than a seeding in the, let's say, the segment of the shaft of the urethra of the penis. It's very uncommon to have it. Most of them occur in the seeding of a previous urothelial carcinoma of the bladder, and these would show the papillary normal aspects. So, for practical purposes, all the distal urethral cancers should be regarded and managed in the same way as the penile cancers.
Yeah, that's very helpful. Well, I think we're almost finished, and if there are any last questions, that would be really good to come from the audience. And I guess we can just finish by, if we're going to, we've got a time for just one more, I think. So you mentioned again in your talk about outcomes, and I wonder just if you could speculate perhaps why it is you think that the HPV, the presence of HPV conveys a better outcome for these patients.
Well, that's a very good question, because, you know, HPV cases of head and neck have a better outcome. We know this epidemiological. So there is a truth which is based on historical epidemiology that shows this to be a thing that we already know. The other thing is that probably is because they allow the treatment by radiation therapy in a more successful factor. We don't know if this is the case or no on penile cases, because, you know, I usually say that we need to start on ground zero again on penile cancer management, because for a long time we were putting on the same basket orange and lemons, which despite being citrines, they are different in terms of taste. And we need to start looking more careful on penile cancer on both settings. And for the setting of the HPV associated, I'm quite, you know, optimistic in that we can, in a disease which is so psychologically damaging, which has been for about a century only treated with surgery and mutilation, we can be more successful in applying in specific settings radiation therapy with organ preservation, with controlling the morbidity, even on the inguinal areas, in the same way as we were able to change from the abdominal perineal resections on anal cancers to control by radiation therapy and mutilation surgery on the head and neck just by radiotherapy. But for that, we need to, you know, start progressing a long way, and the P16 immunohistochemistry is the first step to allow this to go on the future.
Thank you very much. There is another question which I'll ask you to respond to online afterwards, but in the meantime, that's all we have time for in this webinar. Participants should be aware that the webinar itself has been recorded, and it will soon be available on the college website for members and fellows of the college, and you're asked to refer to that and with any of your colleagues who weren't able to join us today. You should also know that the professional guidelines team will be sending around a brief questionnaire asking for your views on what this webinar was like and how you felt the experience was for you. Finally, it remains for me just to thank Pedro and John for sharing their experience with us and addressing really interesting questions with an interesting discussion. And so thank you for the work, first of all, of producing these guidelines, and today for delivering this really interesting and helpful session to us. Would also just like to mention with thanks the Guidelines team, Rhys Carfrey, Cynthia Mitri and Maria Marrero-Feo for all the work that goes on all the time to ensure that these guidelines are produced and maintained up to date. Finally, let me thank you all for coming to this webinar and participating, giving us your questions and being involved in it. Finally, there are some new webinars coming up. We've 2 in December and one about a salivary gland pathology and the other about cardiovascular pathology. And I look forward to you all being at that. I hope you have a good day. Thank you very much. My name is Peter Johnston.